Shiva, we're coming to you.
Yeah, so, Alison, are you able to hear us?
This looks like the inside of an Indian cath lab.
Yes, I'm able to hear Dr. Jim Locke.
Here we go. Madras Medical Center.
Dr. Locke, I'm able to hear you.
Welcome.
Are you able to hear me?
I can certainly hear you, and we can see you.
Thank you.
And it looks like you guys are about to do some work.
Yeah, sure. Can we show the patient details now? Dr. Shanj?
Good afternoon, everybody. This is Sean. I'm going to be taking you through the clinical presentation of the next case. This is a baby 3 months of age, current with a birth weight of 2.6 kilograms. Due to an abnormal right heart structure which was detected antenatally, the baby was diagnosed with supracardiac TAPVC and referred to our cardiac unit here at M Hospital. Subsequently, here at our hospital, we had a fetal echocardiography that was done at 36 weeks of gestation, which detected an RPA to LA window. Just a small academic recap on the types of RPA LA window. We have 4 types that have been described. Type 1, where we have an RPA with normal pulmonary veins, but a fistulous channel connects the RPA and LA. Type 2, the right lower pulmonary vein is absent and the lower lobe RPA branch drains directly into the LA as an aneurysmal sac at the insertion site of the right lower pulmonary vein. Type 3, where we have the pulmonary veins drain directly into the abnormal channel that connect the RPA and LA as a fistula. Type 4, where we have the right lower pulmonary vein, which is replaced by 3 other smaller veins connecting the aneurysmal pouch, with the left pulmonary veins joining LA directly. Going back to our patient, on examination, good general condition, saturating in the neonatal period, the oxygen saturations were about 80 to 90% when the PVRI was high, lately slowly improved. Weight of 5 kilos, pulses were normal, cardiac examination was normal. ECG was a sinus rhythm with a ventricular rate of about 140 with a normal QRS axis. Chest X-ray, cytosolitis levocardio with a cardiothoracic ratio of about 55% with pulmonary oligemia. A fetal echo demonstrated a dilated aneurysmal-like sac that drains into the roof of the LA. Color flow Doppler shows a fistula drainage into the roof of the LA. A gradient across this fistula was about 68 millimeters of mercury. A repeat of the echocardiography in the neonatal period, subcostal view demonstrated this aneurysmal sac with a fistulous drainage of the RPA to the roof of LA with an orifice that was measuring about 2.5 millimeters. A gradient across this orifice was about 42 millimeters of mercury. A repeat echocardiography done at 3 months of age showed a dilated RPA and aneurysmal-like sac which was draining into LA. An aneurysmal-like sac which was draining into LA. On a suprasternal view, we demonstrated the same aneurysmal-like sac with an RPA to LA fistula with normal pulmonary veins. The gradient across the orifice was measured about 11 millimeters of mercury. The plan for today is to have a device closure of the RPA to LA window, which is an unusual anomaly that leads to cyanosis with normal cardiac auscultatory findings. Thank you.
So, hello.
So, before you go on any further, I'm confused. Do the pulmonary veins drain normally to the left atrium in this patient?
Correct. Actually, the anatomy that was present was window-like communication between the undersurface of the right pulmonary artery to the roof of the left atrium, which causes a shunt of the blood from the right pulmonary artery directly into the left atrium. When we saw in the fetal period, the pulmonary artery...
Okay, so...
The pulmonary artery had very high pressure, so we had high gradient. With the fall of the pulmonary vascular resistance, the gradients have come down. And we are finding that the fistulous channel that we are seeing is progressively increasing in size. What was measuring about 2.5 millimeters in the neonatal period is now measuring about 5.5 millimeter, and so we decided to take up this child for a diagnostic study. I'll just show you the anatomy that we have got. Can you go on fluoroscopy? So the patient had a very patulous foramen ovale through which we could advance the catheter into the left atrium. The right and the left atrial pressures were a mean of 8 millimeters of mercury. The pulmonary artery mean pressures were 16 millimeters with a systolic of 21 and diastolic of 10. When we advanced the catheter into the right upper pulmonary vein, we could appreciate the right upper pulmonary vein draining normally. However, the portion of the left atrium near the region of the right pulmonary veins was aneurysmal. Next picture. So then we took a catheter into the main pulmonary artery, freeze the frame, freeze it. So we can appreciate the whole of the main pulmonary artery is significantly dilated, and from the lower surface of the right pulmonary artery, there is a communication that goes and fills the left atrium. In order to get a better picture, we pointed the catheter towards the orifice and made another injection. And here we can appreciate that the catheter is now inside the left atrial aneurysmal pouch, and as we are injecting, the catheter bounces back into the dilated right pulmonary artery. The saturation of this child today during the procedure varied anywhere between 80% to 93%. Right now, what we have got is a catheter that goes from the right atrium through the left atrium and entering into the window, and another catheter is positioned in the main pulmonary artery for a check angiography. A communication between the right pulmonary artery and left atrium, which is slowly increasing in size in the last 3 months since birth, from 2.5 millimeter to 5.5 millimeter. Is our audio, are you getting the audio signals? Hello?
Yeah, so personally, this is Jim Locke. I'm a little tiny bit speechless here. I don't know, in the 30 years that I've been in Boston, we've probably done 60,000, 50,000 catheterizations, and I don't think I've seen this more than twice. Okay, whatever this is extremely unusual. And as a result, I'm sure transcatheter therapy makes sense here, but you're going to be making this up as you go along, which we've never done before, actually, in the history of the field. So I'm very interested to see how you're going to handle this.
Yeah, Dr. Jim Locke, let me also tell you, I had the sweet fortune of coming to your lab in 2001 and spending 3 months with you in your lab with Barry Keane, all your nice team. And I had enjoyed my stay in Boston almost 17 years ago. And what we are planning to do today is, since the orifice on the echocardiogram was measuring about 5 millimeters to 5.5, we have decided to take an ADO2 device, which is a relatively sleek device, focus in. So ADO2, 5 millimeter waist and 4 mm. So what we have got right now is 2 catheters. As I pointed out earlier, one is coursing through the window into the right pulmonary artery. So currently we are advancing the catheter, advancing the device. I am getting the audio only intermittently. I wonder whether our signals are reaching Frankfurt. Dr. Allison?
Your signals are reaching perfectly. We can hear everything.
Thank you. Thanks a lot. So right now our intention is to open up the disc in the pulmonary artery, and we are going to make a small check angiogram through the pulmonary artery. Unfortunately, the catheter is directed the other way. So we have come to the point of occlusion. Fluorostore. Store this, show this. So we have released the device based on the fluoroscopic anatomy. So freeze it. So the pulmonary artery side seems to be well opposed. And go to the levo phase. Freeze it. Go back. The left atrial side also seems to be okay. Positionally, we feel that we are reasonably good.
I would certainly agree with that.
So now we would like to get some echocardiography. Go echo live. This is going to be a transthoracic echocardiography. We don't have, the child is under sedation, breathing spontaneously, and not on intubation anesthesia. Yeah, make it bigger. Make it much larger. Yeah, color. So that is the superior vena cava color into the right atrium. And we can see the right pulmonary artery, which is large. There is not much of flows that we are seeing on the color from the RPA into the LA. We can see the patellus PFO, or maybe a secondum atrial septal defect which is flowing left to right. That is the right upper pulmonary vein. The right upper pulmonary vein flows are also good. Anatomically, it seems to be in an acceptable position. I can release the...
Is there a possibility that the right lower pulmonary vein...
Right lower...
Is there a possibility that the right lower pulmonary vein is being interfered with by the device? Can you show us the leva phase again of that injection?
Show that injection again.
Is that the pulmonary artery side is... Pulmonary artery side is perfect. You don't have to worry about that at all.
Yeah. Yeah.
The only thing you have to worry about is the left. That looks pretty good. I agree.
Yeah. What I will try to do is get my catheter deeper into the right pulmonary artery and try to give a better angiogram, because right now my catheter is more into the main pulmonary artery. Keep tracking. Yeah. Enough.
Excellent. Thank you very much. Let's see what this looks like.
So I'll make an angio now. The right lower pulmonary vein seems to be at a much lower level. Freeze it.
I agree.
Yeah.
And the right upper vein looks wide open also.
Yeah. So I would like to...
Very nice picture there.
Yeah, so I'd like to release it now and maybe just make one more picture. Since this is a duct occluder type 2, closure may take a little longer. I'm finding the saturations are right now around 93%. The child is not on any supplemental oxygen. We need to maybe wait till the effect of heparin goes off in order to see whether there is a complete disappearance of the
Any comments from the audience here? There's a comment back there.
Shiva, Nick Hayes from the UK. Fantastic results. I'm just wondering, how did you decide on using an ADO2? Did you think about using just a septal occluder, a small septal occluder? That would have been quite flat too. How did you come to a decision about using that particular device?
I think that's a good question.
The discs of the septal occluder will be about 6 millimeters more on the pulmonary arterial side if I am using a 4 mm atrial septal occluder. So it will make it 4 plus 12, that is almost 16 millimeters on the pulmonary arterial side, whereas this 5 millimeter duct occluder 2 will have 11 millimeter disc. I agree that the pulmonary artery looks dilated, but it may be too small for a 4 mm Amplatzer septal occluder, because 4 plus 6 plus 6, it will be 16. And the amount of metal there will also be a little bit more. We can see that the flow has almost stopped even now. Maybe there is a little bit of foaming. What will be interesting will be to decide on the antiplatelet or anticoagulation strategy. Now, Dr. Shan, who is my colleague, was presenting the different types of right pulmonary artery to left atrial windows. Some of them are associated with a aneurysmal pouch in the left atrium, as it is in this patient also. So there may be some slow flow in some corners of the left atrium. And I wonder whether a short course of an anticoagulation for maybe about 6 months or 1 year may be a better strategy. I have personally closed only one before, and that was a little grown-up child, and that did not have an aneurysmal pouch in the left atrium. And so we put in a Amplatzer duct occluder 1 device. It was published in the Catheterization and Cardiovascular Interventions many years ago. But this is a pouch that is seen on. So I'd like to get the views of Dr. Jim Locke.
We're going to be ready to go to Frankfurt.
Is there anybody else who wants to comment on this before I expound? Wait, before I say anything, I have to put my blue glasses on. Anybody else wish to comment?
Shiva, we will be ready to go to Frankfurt very soon.
Well, you've got more hardware in the left atrial side than you have in the pulmonary artery,
Yes.
right?
Yeah.
And given that, I would agree completely that this kid is at some risk, and I would agree that this child is at some risk from embolic events from the left side of this heart. And I think that the risk of relatively aggressive anticoagulation here would be relatively small. I don't know about the rest of you, but we're getting a fair amount of experience now using Lovenox to treat vascular occlusions in babies, and that seems to be a very safe therapeutic approach. So, me personally, I would probably vote for a number of months of Lovenox in this baby. Does anybody else have any thoughts?
Yeah, I fully agree with Dr. Jim
Allison
Locke.
has instructed me that she would like a vote. How many people would just use aspirin, and how many people would use something more aggressive than aspirin? Aspirin first. Yeah, I'm seeing several relatively conservative people raising their hands. Then how about something more aggressive than aspirin? That seems to be rather more common. And I think it's the blue glasses effect.
So I also personally.
Okay, thank you very much.
Thank you. Thanks a lot.
That's a great case. That's a great case. And